Hi everyone, welcome back to my channel, Health by Heather Hirsch, where we discuss all things menopause, perimenopause, and hormone related. I'm so glad you've landed here. If you like this channel, if you've been watching a couple of my videos, please go ahead and subscribe because that lets me know you guys like this type of content and I can make time in my schedule to make more for you. I love the community that we're building here, so please go ahead and give it a thumbs up and subscribe. Before we get into today's video, we're going to actually be discussing surgical menopause versus natural menopause, a topic I've gotten a lot of questions on and requests to do. Before we get into that, I do want to let you know and put up my disclaimer that this is not to be taken as direct medical advice. This should be for educational and advocacy purposes only. And my channel is not sponsored by my institution, and these views here represent my own. So that's important for me to let you guys know that. And also there's a couple other fun places. If you want to follow me, I'm on Instagram at hormone.health.doc and Twitter at HeatherHirschMD. And I know a lot of you guys know I have a podcast. It's called Women's Health by Heather Hirsch, and I will link that down below. The fun thing about my podcast is over there, I cover a wider range of women's health topics, often getting into not only midlife, but reproductive health, pregnancy, postpartum, and sometimes just whatever the heck I want to talk about. So you can check out my podcast. New episodes come out Wednesday, and you can find it pretty much anywhere that you guys get your podcasts. So with all of that out of the way, today we're going to be discussing surgical menopause versus natural menopause. And I want to break down a lot of what happens in surgical menopause, sort of myths and misconceptions, and also why it's a lot different from natural menopause. So let's start right off the bat with a quick anatomy lesson. So I'm going to put up a picture right here and kind of talk over this picture. And the reason I'm doing so is just much easier to see a picture and know what the difference is. So in surgical menopause, this means that both of your ovaries are removed. So when we're looking at the female reproductive system, you've got the vagina, which ascends to the cervix, then you have the uterus, you have the fallopian tubes, and your ovaries that are on both sides, and that's where all your ovarian tissue, your follicles, your estrogen is made. They're the good stuff. And so that's kind of the anatomy of your reproductive tract. A lot of people will tell me when I ask my patients about their female reproductive surgeries, they'll say I've had a full hysterectomy, a partial hysterectomy, and these are actually slang terms. I actually want to encourage you not to use them. I mean, you still can, but it's just that it's, again, it's a slang term. So you always want to ask your doctor and always want to be informed about what you actually had removed, because believe it or not, a lot of people and patients and women don't know, and that's okay. It's confusing. If you didn't go to medical school and you're not a healthcare professional, you don't necessarily need to know, but it actually does make a difference. So let's go over some of the medical terminology. Oophorectomy or bilateral oophorectomy. Bilateral means both sides. Bilateral oophorectomy means both of your ovaries have been removed, or is the removal of both your ovaries. A hysterectomy is a removal of your uterus. And so those are sort of the two big terms. So a hysterectomy with bilateral oophorectomy is when your uterus and your fallopian tubes, typically go with your ovaries, are all removed. And lots of people there's just no standard. You could have your uterus removed and not your cervix and not your ovaries. You could have just your ovaries. You could have your ovaries, your fallopian tubes, your uterus, your cervix all removed. And so this actually makes it quite complicated. But what makes it real true surgical menopause is if both of your ovaries are removed. If you still have one, if they leave one of your ovaries, that little ovary can tack up there and can secrete estrogen and actually do a pretty good job. And so if you still have one ovary, you won't be necessarily put into surgical menopause, although there are some consequences to that. But again, immediate surgical menopause is when both of your ovaries are removed in surgery. So I know I've kind of beaten that point down, but it is really complex. So what are the reasons people will have both of their ovaries removed? Well, there's a few, and this list will probably not be exhaustive, but there's a few. The first reason people will have surgical menopause is actually a historic one. So back about, let's say, 20 or 30 years ago, when women would have a routine hysterectomy, their uterus removed, and common reasons for that are fibroids, uncontrollable bleeding, concern for uterine cancer, any type of cervical cancer that's spread. Those are big reasons to have just your uterus removed. At that time, it was a little bit more popular and more common that while your gynecologist was in there, they would just scoop up your ovaries and take them with you. And the thought process, and again, I wasn't a practicing physician then, and I don't want to speak for others, and I'm again making a sweeping generalization of history, but the thought was that, well, your ovaries can cause cancer, and so we're here, let's just take them out. It's probably going to reduce your risk for ovarian cancer. And so they were taken out without much consideration of the drastic and pretty immediate and long-term effects of having induced menopause. Now, you might be saying, what if they take your ovaries out and you're already menopausal? Okay, you're already menopausal. You've pretty much gone to sleep and they're not doing anything. So yes, if you're already menopausal, postmenopausal, at the time they take your ovaries out, it's a little different story. But we're talking about, again, it was much more common during a routine hysterectomy where they took out your uterus, so they took out your fallopian tubes, your ovaries, and your cervix, and they took out everything. What's another reason for both ovaries to be removed? This could also include if there's severe endometriosis. Endometriosis is a condition that can cause really chronic cyclic pain around your periods. It's when uterine tissue is not in your uterus, it's other places, but it responds like it's in your uterus. So every time you have a period, it can feel crampy and uncomfortable. And if it's really, if it's a more severe case of endometriosis, it has reached your ovaries. Sometimes your ovaries will have to be removed. Other indications could be, for example, a tubal pregnancy. And in this case, the pregnancy sometimes implants near the ovary or in the fallopian tube that the ovary can't be spared. Other cases are things like ovarian torsion, where you've got your fallopian tube and then your ovary at the end, and the fallopian tube torses or twists on itself, almost like a twist tie, and that can cause no blood supply to go to the ovary. It can become necrotic, infected, and it has to be removed. Of course, ovarian cancer, you must take your ovaries out, take your ovaries out if you have ovarian cancer. Along the lines, but different than just ovarian cancer, I'm going to shift a little bit here, is a lot of my patients will have their ovaries removed for a BRCA mutation, either BRCA1 or BRCA2. A BRCA mutation, if you don't know, I'm sure a lot of you do, means that you carry a very increased genetic risk for developing either breast and or ovarian cancer. And the current recommendations for anyone who has a BRCA mutation is to have your ovaries removed after you're done childbearing or around or by age 40. So that will put you at menopause in your late 30s to early 40s. So those are some of the main reasons and indications that ovaries are removed. Again, that list is not entirely exhaustive, but those are going to be the most common ones that you'll find. So what happens right after your ovaries are removed? Well, and you guessed, you're in menopause that day. And that's just what happens. Again, your ovaries make all the estrogen in your body, and when you remove them, you are certainly into menopause on that day. Before I go into surgical menopause, let's talk about one other surgical procedure, which is when the ovaries are spared or one ovary is left or etc. What your surgeon does, and I am not a surgeon, but I was an OBGYN resident for a year or so, and so I know a little bit about it. But what your surgeon will do if they're sparing your ovaries is essentially tack them up somewhere in the pelvic bowl, because again, most of the time they will take out the fallopian tubes or some kind of combination. And what's important to know about that is that can affect your menopause based on how difficult the surgery was. If, for example, a ovarian tissue was nicked, some ovarian tissue was lost, or the vascular supply, meaning the blood supply that's letting that ovary grow, like a plant, if you will, is nicked in some way, you can actually go into menopause earlier than if your ovaries were never touched at all. And so that's important to know. So if your ovaries are removed, menopause that day. If you kept your ovary or one ovary, you could certainly go to the natural age of menopause that you would if no one touched your ovaries, or you could start having symptoms earlier based on how difficult that surgery was. Whew, a lot to know. Okay, so my windows are open. I hope you guys are not hearing a lot of background noise, but it's literally the only way to film in this room because it is really hot, so I have to keep the windows open. So sorry for any background noise that may be disturbing. If it is, do let me know. All right, so if you have surgical menopause, there's in some cases a notion that you are younger than what would be your normal or natural menopausal age. And that certainly has some big indications. And I alluded to this when I said historically when ovaries were removed, when the uterus was removed just because they were there wasn't a lot of consideration for the long-term effects of surgical/early menopause. So the surgical part as one component because it's so fast. You know, there's sort of, again, there's a lot more research that needs to be done, but there's less, of course, of this gradual change in your hormone levels and your body adapting and receptors adapting and all the sorts of proteins that change and metabolomics and DNA and all those teeny tiny crazy really cool microbiology things. It really is just a split second where all of a sudden it can be quite a shock to your system. So surgical menopause patients typically are younger than when they would have normally have had menopause, and so not only is it the rapid and immediate, but it's also their age. So let's talk about age, because we just talked about how the rapid can have a big effect. Age is really crucial, and I'm going to talk about premature ovarian insufficiency for a second and make some correlations. Premature ovarian insufficiency, or POI for short, is when menopause is diagnosed before a woman turns 40. After a lot of really good research, we now know that the gold standard is that those women with POI should be given estrogen and progesterone if they still have their intact uterus, possibly even plus or minus some testosterone, because the cardiovascular effects of losing your estrogen really early increase your risk for future cardiovascular events, as well as reductions in quality of life and sexual function, in terms of sleep, in terms of mood, many outcomes if women with POI are not treated with hormone therapy. And so now I'm going back to surgical menopause. If your surgical menopause was early, and I've seen many patients very early, in their teens sometimes, very rarely, in their 20s and their 30s, physiologically that's very similar to patients with POI, where the gold standard is to treat with hormone therapy. So if it's early surgical menopause, I really think there is a big role for you to consider hormone therapy at that time because of the big effects that it can have throughout your entire body when you go into surgery immediately. So not only are there risks for cardiovascular events, but also we're thinking about, again, quality of life, brain function, and chronic conditions which tend to develop around the time of menopause. I don't want to state there's an absolute correlation. It's just something, a large association that I see. Okay, back. I had to quickly shut my windows because someone is definitely trimming their bushes, and so it is a little bit loud. But let's get back to some of the complications that can happen with surgical menopause and early surgical menopause if you're not treated with hormone therapy. So we talked about cardiovascular events, and so that's one thing to consider is actually the use of estrogen and or progesterone if you still have your intact uterus for heart benefits and also bone health. We do know that, again, you lose the most amount of bone when you go through menopause. If you're younger and if it's surgical, it can be quite drastic and it can have a big effect on your bone health. So another indication or reason to consider estrogen replacement is for your bones. And then thirdly, and of course really huge, is that quality of life. A lot of times women with surgical menopause have almost instantaneous, or actually sometimes like 2 or 3 months delayed, severe hot flashes and vasomotor symptoms. And again, I always say that hot flashes don't always have to be that typical, coming from the ground or your feet up to your head and coming back down. They can be just increased warmth. They can be night awakenings. And those types of vasomotor symptoms are very disturbing. Of course, let's not forget sexual health, which is so important to somebody who may be in their 30s and 40s. Without estrogen replacement, you can have severe vaginal atrophy and vaginal dryness, which can cause a pain with intercourse and urinary tract infections, among just others, like feeling uncomfortable with sitting or walking. So surgical menopause is certainly more drastic and oftentimes more severe. Another indication or another special population to consider is for those BRCA patients who have their ovaries removed, who do not otherwise have a history of cancer. This is actually a very special patient population that I see very commonly. In fact, I can do a whole video on this if you'd like. Please drop me a message in the comment section. But those patients also should definitely have a consult about what they could experience after their ovaries are removed, because many of these patients are very proactive. They want to have their ovaries removed to reduce their risk of cancer, but they also should be thinking, what after I've done that and I don't carry a diagnosis of cancer, what other risks from that surgery could I face that could affect how I function as a wife or a mother or a colleague or a sister, etc. And so there's a lot to consider, and I do have some patients who are BRCA cancer negative after the oophorectomy who do choose to take hormones, and some who choose not to. But I do think a consult where you sit down and you really map out and think about the aftermath or the after effect of having those ovaries removed is really, really vital and definitely going to be informative. Before we kind of end this, there's another group I want to talk about, which is the women who have one ovary in. So what if you have one ovary in? All right, this is always a little bit tricky, but it makes the detective work on my end really fun. So if you have one ovary in, again, I alluded to that little ovary could kick until natural menopause. The average age in the United States is 51 and a half, so you could go to 51 and it will do just fine. Kind of like how you only need one kidney, fun fact. Again, sometimes if that ovary has been nicked or the surgery was difficult, or even if the surgeon says it was fine, you never know what could happen when you move that ovary. So those patients, if their ovary was moved and maybe they also had their uterus removed, it can be really confusing to know when menopause is happening. If their uterus was removed, they can't go by their periods. They're not going to have any bleeding. And so the only thing they can really go by is symptoms that they're having. But also, I will sometimes check my patient's FSH or follicle stimulating level. Maybe not necessarily routinely, but I will check it every once in a while, maybe once they start developing a few symptoms, once they start getting up into their mid-40s. Because as that number goes up, that is the main indicator that you as the clinician is going to have, and you as a patient is going to have to know when you are hitting menopause. And I do want you to know that that ovary can either remain perfect function, or it can kind of go to sleep and close down shop earlier than you think. So checking an FSH level is really important. I'm going to link here the video on how to interpret your labs, and you can check that out there. It's really informative. So again, in summary, there is a lot of reasons people have surgical menopause. And surgical menopause simply means you've had both of your ovaries removed. And it could mean a consolation of if your uterus is still intact, if your cervix is still intact. And knowing what you had removed and knowing what surgery you had is really, really helpful and important. Number 2, surgical menopause tends to be at younger ages and tends to be more severe in terms of the symptoms that you may feel either immediately or shortly thereafter, after a brief buffer period. And number 3, or thirdly and lastly, they have long-term consequences, particularly if you were younger when you had your ovaries removed, and particularly if you're suffering with symptoms. I do think it is a great time to have a conversation with your doctor either before or after surgery about considering the use of hormone therapy, especially in the instances where you're younger. And then again, we also talked on briefly the special patient population who are BRCA positive, who don't have cancer, who can have a detailed conversation with a menopause expert on the use of hormone therapy after their ovaries have been removed. So there's a ton to learn, and I hope that was helpful. Anyways, feel free to leave me a comment below. I love your messages because the goal, or my goal really in doing all this, is to bring about awareness, open the dialogue, and get people talking. I love your suggestions on videos because I could make a long list of suggestions, but if that's not what you guys feel as though you need to learn or that you want to deconstruct, I need to know what you want to hear about. So please leave me a message in the comments below. You can always follow me on Instagram. I'm at hormone.health.doc, and weigh in there on any topics and send me a direct message. I love reading them. So please go ahead, like this video, subscribe if you haven't already. You know you love it. And plus, also, it's hot in this room and I do this for you guys. Have a wonderful rest of your day or evening, and I'll talk to you guys again next week. Bye.